So now we're on Learning Plan 4, which is Managing Care for Patients Experiencing Personality Disorders. So this is covered in Chapter 24 in Varkarolus. So just as a definition, personality disorder is a psychological disorder that involves behaviors that make it difficult for a person to succeed in interpersonal relationships. And actually, in addition to not being able to succeed in relationships, it also makes it very difficult for them to succeed in other types of life goals, such as working and developing a career and having a consistent job. So all those different types of activities of daily living, including work and their relationships, can be deeply affected if they have a personality disorder. And a personality is kind of our own individual characteristic pattern of relating our thoughts, feelings, and behaviors. It kind of defines really who we are. We all have different types of personalities. I would bet that in this class, you could each look at each other and talk about each other's various types of personalities. Some people are more quiet, some are more outgoing, and we all have different styles to our personality. It really becomes a disorder when the functioning is consistently maladaptive, complicated, or dysphoric, which means that the mood is kind of fluctuates and is usually low or irritable, angry. So there's a mood alteration that isn't a normal way to have a euthymic mood. So that's kind of when personality kind of becomes a disorder. So it really is an enduring pattern of communication and behavior. So on this slide, it's a really nice, neat little slide that I found online, kind of describing the personality disorders in a nutshell. So you don't need to memorize if they are from cluster A, cluster B, or cluster C. That really doesn't matter that much to me, but they are clustered in terms of kind of common characteristics. For example, cluster A is the odd and eccentric types of personality disorders. Cluster B is the dramatic or emotional personality disorders, and cluster C is the anxious and fearful disorders. So they all have some similarities, and that's why they're put into clusters, but you really don't need to memorize which cluster they belong to. But I do think this is a nice slide because it gives you just a very quick overview of the different characteristics of each of the personality disorders, such as paranoid. People are usually suspicious, hypersensitive, and especially to criticism, and to be evaluated by other people, and they're kind of secretive. Schizoid, they're seclusive, they're loners, they're passive, they're very indifferent. They could care less if you like them or you don't like them. Schizotypal, they're kind of odd in their thinking. They might have some bizarre fantasies, and they even may speak kind of in a peculiar manner. Cluster B, histrionic, is attention-seeking, flamboyant, provocative. Borderline, they're very impulsive, self-mutilative, and manipulative. Narcissistic, they have excessive self-admiration, egocentric, and a sense of being grandiose or better than other people. Antisocial, they break rules, they're aggressive, they're very abusive towards others. And then cluster C, avoidant, they fear criticism, they're overly serious and withdrawn. Dependent, they're clingy, indecisive, and submissive. And obsessive compulsive personality disorder, they are perfectionistic, possibly passive aggressive, and very rigid and inflexible in the way that they go about their life. So again, just it's a nice checklist of kind of like the most common symptoms of these disorders. I just want to note that obsessive compulsive personality disorder is not the exact same thing as OCD or obsessive compulsive disorder. They have some similarities, But the people with the personality disorder, it's really an enduring pattern of, again, communication and behavior, thoughts and feelings. They don't typically have um, the obsessive thought and then the compulsive behavior as far as like hand washing or checking things over and over again, touching things. They don't have those types of compulsive behaviors. It really is more of a pattern of how rigid and inflexible and perfectionistic that they are when they are carrying out their day-to-day life. So just a nice little table for you to kind of refer to. So the epidemiology and comorbidity. So the epidemiology, it's kind of confusing sometimes as to what really causes personality disorders. The prevalence, it's about 6% of the global population. So that is actually a significant amount of people. It's seen in up to 50% of psychiatric patients. Many patients, however, are not necessarily hospitalized because of their personality disorder, but many times it's a secondary diagnosis, but it certainly is contributing to their lack of being functional, and it may contribute to their having really some very difficult behaviors when they're on the outside. So we do see a lot of people with personality disorders, but again, it's rarely the only cause for their hospitalization. Usually they would be hospitalized for being suicidal, possibly for being depressed. People can even have schizophrenia and have a personality disorder on top of that. So if you have, comorbidities are really important to look at. Substance abuse disorders, many times people have that comorbidity of having a personality disorder and they abuse substances. So they may end up in the hospital because of the substance abuse. But we do have to consider that personality disorder because it's probably going to make them a little bit more difficult to treat and to interact with. When we have a personality disorder, the emotional dysregulation is really amplified, especially if they do have, again, another disorder, such as depression, bipolar, schizophrenia, substance abuse disorders. There's quite a few risk factors. There's some genetic predisposition, neurobiological, psychological, environmental, and again, that diathesis stress model, the genetic predisposition, and then that interacts with stressors. And many times we do have to look at the environmental stress of people that have personality disorders, especially borderline personality. People with borderline personality truly have had very difficult childhoods. They did not receive nurturing. They may have had abuse and neglect situations in their life. Generally, they just have not had a very successful, happy, nurtured childhood. So that's something that is a very common thread for many of the personality disorders, but especially for borderline. For some of the psychological risk factors, your book really talks about some of the use of some of those primitive defense mechanisms. So again, I put that as kind of a standalone PowerPoint and narration, just because you might want to at times refer back to that. So people with personality disorders are many times using a lot of those types of defense mechanisms, and we'll talk about a couple of those as we get into some of the specific disorders. Okay, so now we're going to get into talking about some of the specific disorders. So first, we're talking about paranoid personality disorder. About 2 to 4% of the population has this disorder, and some of the characteristics might be apparent in childhood. Some of these children start out having some social anxiety. They become jealous and controlling as adults, and they're unwilling to forgive, kind of rigid that way, and they use that defense mechanism of projection. So if you kind of remember what that was, projection is when you actually feel a certain way, but you are attributing that feeling to somebody else. So if you have murder in your heart, you're saying other people are out to get you, when actually you are the one that is feeling homicidal towards other people. So that's kind of a common defense mechanism that they use. Slightly more men than women actually have this disorder. Okay, so I just had to take care of that little window that popped up that told me my computer was going to restart in the middle of um, my narration here. So anyways, I took care of that, so now I can get on with the rest of this recording. But anyways, I was saying that slightly more men than women are actually diagnosed with paranoid personality disorder. Treatment, a little bit difficult because sometimes people don't seek help with this disorder. So they have just a general mistrust. They may not even want to go to a doctor because they're not going to trust the doctor's motive. They may not trust your nursing care because they're not sure about your motive. They're kind of suspicious and wonder if you're really going to help them or not. So it is really helpful to try to, if we do have them in the hospital, to try to counteract that mistrust by adhering to a schedule. Again, just being very consistent, which means doing what you say you're going to do when you say you're going to do it. So if you say I'm going to be there at noon, you better be there at noon. I know that sometimes that can be, you're probably thinking, that's probably difficult because you never know if, you have more than one patient, you never know what your day is going to be like, and you don't know if you're going to be in the middle of a crisis or an emergency situation. It's hard to keep promises, but certainly you can do your best. And if a situation does come up where you are in an emergency situation and you can't quite keep your secret, you can't quite keep your promise the way that you had wanted to, it's always good to very openly communicate that with the patient so that they just don't think you blew them off, that you really are concerned about their reaction if you are a little bit late or if you're not able to do what you said you're going to do. You do want to so try to adhere to a schedule. You do want to try to avoid being overly friendly because they're not going, first of all, they're just not going to accept that. They really would be very suspicious as to why you're being so friendly to them. So it is really better just to be very neutral but kind. You certainly don't have to come across strict, stern, and mean, but you can come across just very neutral, matter of fact, and have a kind affect. And if you're consistent over time and you continually honor your promises that you make to the patient, and you're constantly working on trying to develop a rapport with them and have a lot of respect for the way their personality style is, then eventually it is possible to have a positive rapport with somebody with this disorder. Psychotherapy is probably more helpful than group therapy. Of course, it'd be great if they could go to group therapy because then they can get some feedback from other people. But many times people with this disorder really don't want to be around other people, and they really don't want to. They don't trust people, so they're not going to be very open about their feelings. They may need some short-term antidepressants if they have some difficulties with their moods. May also need anti-anxiety or antipsychotic medication depending on their symptoms. So I found a little comic in a nutshell: paranoid personality disorder characterized by a distrust of others, constant suspicion that people around you have sinister motives, and usually, again, without any basis for that mistrust. Schizoid personality disorder, about 5% of the population. Characteristics: symptoms appear in childhood and adolescence usually. They're loners and they sometimes have poor academic performance. They have increased prevalence of disordered family life. So their family situations might be very chaotic. They avoid close relationships and they can experience a feeling of depersonalization and detachment from other people. So it's really a lifelong pattern of social withdrawal. One thing that is really striking about this disorder is that neither approval or rejection from others seems to have much of an effect. So they really don't care if people approve of them, and they really don't care if people disapprove of them. They just seem very neutral to that. So it's really difficult for them to have any type of friendships, and they divulge in imaginary friends and fantasies. They may have difficulties with employment if interpersonal interaction is necessary. So sometimes people with this disorder do really well in a solitary occupation, like being a security guard on a night shift. So they kind of work by themselves, they do their thing, they really don't have to interact with people too much, and that might be the type of position that is really, acceptable to them. So the guideline for nurses, again, avoid being too nice or too friendly, because they will still be a little bit suspicious about why you're being so friendly. Don't try to increase their socialization. It always seems like a great idea that we want everybody to be social, but it is truly difficult for people with this disorder to form relationships. So if they do develop relationships over time, if they are willing to engage in therapy, it's going to be a really long and slow process, because again, this is an enduring pattern of thoughts and emotions and personality expression, and if it's something that started in childhood and adolescence, it's not something that's easily going to go away. We always have to try to assess for symptoms that the patient is reluctant to discuss, especially if they're having problems with their mood, anxiety, or suicidal ideation. And because sometimes starting back in school, sometimes these students are kind of teased and bullied and singled out because they're kind of loners and maybe a little bit of odd behavior. So if they are in a group therapy situation, we really have to work hard to protect them against the group's ridicule, because it is very possible that they may get kind of picked on even in group therapy as adults. If we can encourage them to participate in psychotherapy and group therapy, it would be great. They might have a difficult time with both of those, but as trust can develop over time, they actually can make some improvements. And group therapy is very helpful. Even if they're silent during group, they may be the type that doesn't want to participate. They just want to listen to others. And it's possible that they can actually get some experience just in thinking about situations and how they might respond just by listening to other people. Antidepressants, again, if they are having those types of symptoms. So there's no medication that is specific really for any personality disorder, but sometimes medications are used just to treat the different types of symptoms that people might have. So again, a little comic strip about this disorder, about schizoid personality disorder. So they don't desire close relationships. So somebody calls up this girl and says, "You're invited to my birthday party," and she says, "Thanks, but not interested." And on Facebook, it looks like she has 5 friends. And she says, "Oh, look at that. That's way too many." Some of this was cut off, but it basically says, "Okay, look at that. That's way too many friends. Need to cut back on this list." So it's 5 friends is too many. Need to cut that back. That is very typical of somebody with schizoid personality disorder. Schizotypal personality disorder. So this varies from 0.64 to 4.6% of the population. Characteristics: severe social and interpersonal deficits, anxiety in social situations, rambling conversations, paranoia, suspiciousness, anxiety, distrust, brief intermittent episodes of hallucinations or delusions, but they're not as firmly fixed as people that have actual schizophrenia. They can be made aware of their own odd beliefs, and they may be vulnerable to involvement with cults or unusual religious or occult groups. So this disorder is actually kind of on the spectrum of schizophrenia, but it is not as severe. We haven't talked about schizophrenia yet. That's the next learning plan. So this is kind of on the spectrum, and it may actually be a precursor to schizophrenia, because some of these symptoms are actually really quite similar. So people with this disorder really don't blend in with the crowd. They have very unusual beliefs, odd beliefs, magical thinking. Sometimes their speech pattern is very strange, and inappropriate affect. So the look on their face, their facial expression isn't always appropriate and doesn't always match the situation. Another main difference between this disorder and full-blown schizophrenia is that the psychotic symptoms are usually to a lesser degree, and they only occur briefly. And when we talk about schizophrenia, we're going to talk about people that have delusions and hallucinations that persist, and especially the delusions, which is the false belief. When somebody has schizophrenia, you cannot talk them out of their false belief, where you might be able to talk somebody out of their belief with schizotypal personality disorder. It's not so deeply ingrained. Nursing care guidelines. We really do have to respect the patient's need for social isolation. They may just really become very, very anxious and distraught in large social situations. And we always have to be aware of and intervene appropriately with the patient's suspiciousness. So the things that we need to do is to make sure that we are, again, trying to gain that patient's trust, being open, honest, tell the patient exactly what you're doing before you do it, and keeping promises that you make to the patient and just being very consistent can be very, very helpful to help them with their suspiciousness. We want to always perform careful diagnostic assessment for symptoms that may need intervention. Again, we always want to ask about suicidal thoughts. They may not necessarily voluntarily tell us about that, so we do need to ask direct questions to find out if they are suicidal, if they have a plan, and if they've ever made any attempts in the past. All of that is really very pertinent information. We always want to withhold judgment or ridicule, and of course that seems like an absolute no-brainer, but there are people that do find some of their odd thoughts and belief patterns, and possibly delusions really kind of difficult to understand, and so they may be the object of ridicule and certainly the object of stigma. Treatment would consist of, again, psychotherapy, similar to what we do with schizoid personality disorder, but your book says at the bottom of page 455 that clinicians have to be aware that these patients might be actively involved in groups such as cults, unusual religious groups, and engage in occult activities. So that's something that we just have to kind of keep in mind. And again, there's no specific medication for schizotypal personality disorder, but sometimes they may benefit from treatment with low-dose antipsychotics. So again, a little bit of a comic strip kind of a representation. They may kind of appear socially awkward, have magical thinking, so in which random events are linked. And like an example, this person has the thought of they got out of the bed on the left side, so now it's going to rain. So another example that I always use in my classroom is that there's a blind that I can pull to kind of block the sunlight. Well, it kind of blocks it at least a little bit. And so when I pull that, an example of magical thinking would be, if I pull the blind down in my classroom, then the sun is going to stop shining. So that would be an example of magical thinking. Histrionic personality disorder. The prevalence is about 2% of the population. The characteristics are that people are excitable, dramatic. They're often very highly functioning. They have bold external behaviors, limited ability to develop meaningful relationships. They are very attention-seeking, self-centered, and have a very low frustration level. They have excessive emotions. They might be very provocative, and smothering in their relationships, and they truly have no insight into their disorder or their role in ruining relationships. It is always the other person's fault. If they do seek treatment at all, because usually they don't think they need help, it might be because if they do have a loss of a relationship, they may have a little bit of depression associated with that, and they may need some help when they have that type of a situation. So the psychotherapy is certainly the treatment of choice, but again, it's very hard to get them to that point of accepting therapy because they truly don't think that they have a problem. So guidelines for nursing care. So what we do when we care for people with this disorder is that we have to realize that their seductive behavior is a response to internal distress. So we have to try to be very neutral when we're working with people with this disorder, because it would be very easy to have feelings, very negative feelings toward patients that have this personality disorder. So if we kind of are able to look at it as it is a disorder, and these are characteristics that might be very difficult to deal with, but it relates directly to an internal dynamic that that person is going through. So we always want to keep our interactions very professional, and we just have to ignore the flirtations. That is really challenging sometimes, and I know it's very challenging for students. So there are times when it depends on the patient, but there are times when I may not even assign a student a patient with a personality disorder, just because it really can be very uncomfortable to try to have to deal with being in clinical and then have to deal with a patient that is displaying some of that flirtatious behavior. It is good to learn how to deal with that, however, and that's something that you may have to deal with in any setting. You certainly will have people with personality disorders in any area of nursing that you choose to work in. We always want to try to model just concrete, appropriate language, help the patient to clarify their feelings, and to teach and role model. Assertiveness are all very helpful things when we're working with people with this disorder. So this is again just a little representation of histrionic personality disorder. She loved being the center of attention. So that is kind of a hallmark symptom that we look for. Narcissistic personality disorder. Prevalence is 0% to 6% of the population. Not quite sure how they come up with some of these statistics. Maybe you're kind of wondering the same thing. Anyways, characteristics. Feelings of entitlement. So the world owes me. Exaggerated sense of self-importance. Lack of empathy towards other people. Truly only being concerned with your own feelings and whatever is going on with you, and really no regard for what somebody else is going through. Having a tendency to exploit other people. Underneath all of that behavior, there really is a weak self-esteem, and they really are hypersensitive to criticism. They may come across as being, super confident and that exaggerated sense of self-importance. So they're going to come across maybe seeming like they have a lot of confidence, but truly underneath it all, they do have a very low self-esteem, and they really do not like to be criticized or feel that they're being criticized by other people. That is really quite a blow to their personality. They have a constant need for being admired by other people. And they have overall, though, less functional impairment than other personality disorders. An example of this personality disorder, or at least I suspect that somebody has this disorder. So a friend of mine probably has this disorder, and it really came to light when she was telling us the story of probably getting a date rape drug mixed in with her drink a long time ago at a party. And she knew who the person was that drugged her drink, and that she really became very, she actually drove herself home after having that, barely made it home, was very, very sick, but decided, because she ended up being physically okay from that experience, she never got attacked or anything, and she recovered. The drug worked its way out of her system, and she recovered even though she was quite ill from it, and she did not pursue legal action. She didn't call the police. She didn't try to have this person arrested, even though she knew clearly that this person had drugged her drink. And it was interesting in talking with a group of friends and how angry some of the other women were, because it was clear that she really only cared about herself and that she was okay, but didn't really care to turn in this person to try to help other people to prevent that same situation from happening. So that could be one example of somebody who is narcissistic. They're really only concerned with themselves. So as long as she was okay, she didn't really care to pursue this and see that other women might be okay in the future. So that's kind of part of that lack of empathy for other people, for what other people might be going through. So guidelines for nursing care, again, to remain neutral is always a very positive thing with most of these personality disorders. We want to avoid power struggles or becoming defensive. And sometimes it's easy to do that, to become defensive. I mean, it's difficult to avoid the power struggles because sometimes they may be asking for something which is above and beyond what other people get. They're going to be asking for favors that nobody else gets, and they really clearly don't understand why they can't have this favor, and they are going to just absolutely wreak havoc, and they are going to be angry and demanding, and they really want whatever it is that they want, even though it's perhaps against the hospital policy. So it is difficult sometimes with them to avoid power struggles or becoming defensive, because we always want to defend our policy, defend our nursing practice, defend our unit. And yeah, it's really difficult sometimes to just kind of stay neutral. It is important, though, to make sure that people understand with this disorder that the rules are meant for everyone. But of course, if they are truly narcissistic, they don't think that the rules apply to them, that they should be able to get, special dispensation and have privileges that other people don't have. It is also helpful to role model empathy, concern and care towards other people. They need to see other people doing that. So it is really helpful for us as nurses to kind of do that for them. So they're very difficult to treat. They don't like to seek help. They're not likely to seek help or confront their own shortcomings. It's kind of threatening to them to get in touch with that side of themselves that really isn't very confident. So it's difficult for them to seek therapy because they would have to work through those difficult feelings. But certainly cognitive behavior therapy would be very helpful. Group therapy is also helpful. They can again receive feedback from other people, which can help them to grow. Possibly use of lithium for mood swings. So again, a little comic strip representation why, yes, the world does revolve around me. And in this comic strip rendition, also the person kind of has a crown on his head, and then other people are bowing down to him. So that is truly what the person feels like who has narcissistic personality disorder. Antisocial personality disorder. Prevalence is about 1.1% of the population. Characteristics are antagonistic behaviors, disinhibited, profound lack of empathy, and absence of remorse or guilt. So these are patients who many times are ending up in the legal system. They are ending up in prison because they are committing crimes. They have that much of a lack of empathy for other people that they would kill somebody to get what they want. They are the people that are con men. They con people out of money. This would be the type of person that might marry several different women and con them out of all their money. So they can come across as very superficial and charming and loving and wonderful, and they con people out of their money. So that's the type of person that we're talking about. They do end up in the mental health system. We absolutely have seen people with antisocial personality on the mental health unit, but many times they also have a history of being in jail or being in prison. This personality disorder actually has really significant social impact. So your book actually kind of separates it out on page 459 and really highlights the fact that this is a very serious personality disorder because they truly have disregard for and violation of the rights of other people. So they may commonly be referred to as sociopaths. So sometimes people might think of antisocial as people that are quiet and loners and they don't like to socialize and be around other people, but that is absolutely not accurate. So there's a big difference between being asocial, which means that you don't really like to socialize and be with other people, you're kind of a loner, and antisocial. So antisocial is also, you might have heard that term sociopath. That's another way that we can think about this diagnosis. So it is totally reserved for adults, but symptoms are usually evident in the mid-teens and can even start in childhood. And when we discuss, I think it's Learning Plan 6, that's the childhood disorders, we will talk about a childhood disorder that actually is a precursor to antisocial personality, that if the child or adolescent doesn't get help, they are likely to turn into an a person with antisocial personality disorder. So they have some of the antagonistic behaviors they have. They're deceitful, they lie, they manipulate for personal gain. They're hostile if their needs are blocked. They have disinhibited behaviors like risk taking. They totally disregard responsibility. They're very impulsive. Again, they have that criminal misconduct and substance misuse are very common, and they are really looking for personal power or pleasure. And in their relationships, they really focus on their own gratification to an extreme. They have little to no capacity for intimacy. They will exploit others if it benefits them in relationships. And they are very callous, and they have that profound lack of empathy. They truly don't care what happens to another person. And again, they would kill somebody if that meant getting their needs met. So that absence of remorse or guilt is really very, very much of a hallmark of somebody with antisocial personality disorder, and obviously very disturbing. So the assessment is that we have to realize that patients don't always answer questions honestly. And boy, we really do have to do this self-assessment thing to work with people with this disorder effectively, because they certainly can trigger a lot of very negative emotions in us, especially when we hear their history and we hear about the things that they have done to other people. We've had patients on the unit that have murdered other patients with antisocial personality disorder. They, again, use and abuse and con people. So it really can be difficult to be therapeutic and neutral when somebody has such extreme types of behaviors. So nursing diagnoses that would apply: risk for, usually it's other-directed violence rather than being suicidal. So risk for other-directed violence, defensive coping, impaired social interaction, and ineffective health maintenance because of their impulsivity and many times substance abuse. So outcomes, we want to see that they have behavioral self-restraint, so that they're not being abusive towards other people, that they're showing more appropriate behavior, aggression self-restraint, so we want to see them not being aggressive towards other people, coping better, have better, more appropriate social interactions, and health promotion and health promoting behaviors. And these really are difficult to accomplish because, again, people don't necessarily have a lot of insight. They don't really feel that they need help, and they really can rationalize. So again, going back to those defense mechanisms. They many times rationalize their behavior. Well, that person deserved it. I know I beat them up, but they really deserved it. So they rationalize things, and so it's very difficult to treat them and to meet any kind of goals. So of course, maintaining safety is the top priority, and usually, again, it's maintaining safety of others. There's one patient in particular that I can think of that is admitted to the unit every now and then, and I will not assign that person to students because of the flattery, seductiveness, actually making inappropriate sexual comments, and just that whole aspect of being so manipulative is very, very difficult to work with. So there are a couple patients, one in particular I can think of, that I won't assign to students just because of that degree of difficulty in working with that person. So as nurses, though, we have to try to set boundaries because truly they will try to get away with any type of behavior that they can. So we have to set boundaries for appropriateness, consistency, provide them with support, limit setting, super, super important. We have to offer them realistic choices. They may not be open to that, but that's the choice that they have in the hospital. Teamwork and safety, of course, is of prime importance. Using therapeutic communication. And again, part of that is not being judgmental. It's really difficult to try to get somebody to reflect on their behavior that we know is bad behavior, but they're having a hard time understanding that. So using therapeutic communication techniques to try to draw them out and actually not, we can't be judgmental towards them, but we do have to try to encourage them to reflect on their own behavior. In your book on page 463, actually, I believe this is your discussion question for Learning Plan 4. So on page 463, there's a dialogue with a patient with manipulative, aggressive, and impulsive traits. More than likely, this person has a antisocial personality disorder. So I will leave that up to you to read. It's in a purple table, and there's a discussion question related to that. But it's a really great example of using that therapeutic communication to try to pull somebody out and to truly be non-judgmental. Pharmacological interventions, again, might target their mood symptoms or anxiety, but certainly there is no medication that is specific that will cure or control antisocial personality, but we can control some of the symptoms that they might have. They might need mood stabilizers, and they may actually need antipsychotics to control some of the aggressive type of impulses that they might have. Advanced practice, it might be great to think about having a person in long-term therapy and trying to really help them to overcome this personality disorder through, working on their ways of coping and interacting, but they rarely stick to long-term relationships. So that makes them really very difficult to treat. So again, a little comic strip characteristic representation, lack of empathy, little regard for others' feelings, view the world as hostile, they look out for themselves, they don't think about the consequences, and they are prone to criminal behavior, lying and stealing, and worse, actually murder. They certainly are have been known to also kill people to get what they want. So it looks like a businessman in a shirt and tie and suit jacket is saying, I'll keep it short and sweet. Family, religion, friendship, these are the three demons you must slay if you wish to succeed in business. So in other words, you can't consider family, religion, or friendship. Those things are meaningless to the person with this disorder. It's all do whatever you can to get ahead and, in this person's perception, to succeed. Borderline personality disorder. So the clinical picture is very severe impairments in functioning, emotional lability, which means changeable. So they can be happy, giddy, laughing, crying, sad, irritable, angry. They just kind of are all over the place with their emotions. Impulsivity, so again, little time between thought and action. They have a lot of self-destructive behavior. So when we were talking in Learning Plan 3 about self-harm, non-suicidal self-harm, people with this disorder do a lot of non-suicidal self-harm. They do also make suicide attempts. So both can really be coexisting in the same person. They have, again, that sense of antagonism, and then also splitting, which is that inability to view both positive and negative aspects of others as part of a whole. And again, relating back to the defense mechanisms. So if you look back at that and look at the defense of splitting, so you don't see a person as having both good and, positive and negative characteristics. You either see that person as all good or they're all bad. So usually what we say in mental health nursing is like you're either the good mom or you're the bad mom. And if the person sees you as the bad mom, it's really hard to get out of that. It's almost like you have to just change the assignment and assign another nurse to take care of that patient because it's just really going to be very difficult for you. And sometimes I hear in report or before report starts, the staff are kind of negotiating about taking particular patients, especially if they are seen as the bad mother or the bad mom. So that splitting really does play itself out in some very difficult ways on the unit. And also staff splitting between shifts, pitting the day shift against the evening shift, and vice versa, pitting staff members against each other is all part of the dynamics and the behaviors that we see when people have borderline personality disorder. People that have this disorder are really very difficult to have therapeutic communication with because they are very, very difficult to listen to. They get very, very dramatic when they're talking about their feelings. And you can come away with just feeling completely drained yourself as a person after talking with somebody who has this disorder. The prevalence about 1.6% of the population, suicide, 10% suicide and mortality rate. So we do have to take that seriously, that even though they do engage in kind of chronic self-harm behaviors, many do end up committing suicide. So we do have to really worry about that and make sure that we are paying attention to that. 85% of borderline personality disorder patients have another mental illness. So many times it's depression, anxiety, and sometimes I do see people with bipolar that have borderline personality, and I've seen a few patients with schizophrenia that have borderline personality, and also people with substance abuse disorders. So again, a lot of comorbidities. It's actually a high genetic association with people that have borderline personality disorder. It's 5 times more common in first-degree biological relatives with that same disorder as compared with the general population. So, and that the genetic factors such as hypersensitivity, impulsivity, emotional dysregulation are the things that we're kind of thinking about. So, there is a genetic association with this disorder. There are sometimes what we call separation individuation factors. So basically, the child needs to bond to the mother or the mother figure, but also separate eventually and become an individual person. So they really have to have their safety and security needs met in order to kind of strike out on their own and be their own individual person. So many times, people that have borderline personality disorder truly have a history of trauma, and that trauma can go all the way from infancy throughout their childhood. So abuse, neglect, very difficult family situations, chaotic, disrupted family life. Perhaps their parents had mental illnesses also. All of that can contribute to the development of this disorder. Many times you look at somebody with a borderline personality disorder and truly can say that they just did not have a very nice childhood. They didn't have people around them that cared for them and actually nurtured them and met their needs. So the assessment, we have structured interviews that can be used. The MMPI is something that it's a diagnostic tool that would be used by an advanced practice nurse, perhaps, or a psychologist. It's the Minnesota Multiphasic Personality Inventory, and it's a very valid and reliable scale for the clinician to refer to when interpreting. So, but that is something that we would be aware of the results. We wouldn't, as nurses, be necessarily doing that testing unless we are perhaps an advanced practice nurse. Always need to do that self-assessment. People that have this disorder, again, kind of push a lot of our buttons. They seem to get to the core of our own insecurities, and so it can be very difficult for us to work with people that have this. Sometimes it is difficult to deal with the level of manipulation that they have, that really kind of calls on us to have a lot of confidence in our own abilities to deal with that manipulative behavior. And I noticed that some of you in your discussion questions spoke to the fact that manipulation is something really to work on. It is difficult to deal with because you feel like somebody's trying to make you do something that you don't really want to do or is right to do, but you kind of feel like you're being used to help them get to a goal, but it isn't necessarily a goal that they should be trying to reach. So, boy, that manipulation is a very difficult thing to work on. It does take skill and practice, and really a degree of trying to sit back and look at the situation and not yourself get emotionally involved in it. So that can be really very helpful, just to kind of take a step back emotionally when working with patients that are manipulative. And again, setting firm, consistent limits. And if the communication among all members of the healthcare team is constant, then manipulation really shouldn't be occurring, because everybody should be on the same page and very, consistent with what we're doing. So nursing diagnoses that might apply: self-mutilation, certainly risk for suicide is very high. They usually are chronically suicidal. It is something that may never go away, but it's usually something that as they improve and they have periods of improvement, it can improve to the point where at least they're not acutely suicidal. They still may have some thought processes in their mind, but they're not at the point where they're going to act on them. So sometimes that's the best you can do. Maybe the suicidal ideation is never going to disappear, but at least it can be controlled. They always have that risk for self and or other directed violence, so we always need to assess for that too. Impaired social interactions. They tend to idealize people sometimes. Again, you're in that good mother or bad mother camp, and they have a real great deal of difficulty maintaining appropriate relationships. They kind of pull people in too quickly and try to get too close, and then when things get uncomfortable, they push you away. So it's not a normal flow that a relationship would take. They have disturbed personal identity. Sometimes they describe feeling empty and kind of feeling lost, like they don't really know who they are or what they are. So that is very much a hallmark of this type of disorder. Definitely ineffective coping. Usually the coping is quite maladaptive. So again, cutting, substance abuse, suicide attempts, any type of impulsive behavior is all considered ineffective coping. So when we're thinking about outcomes and planning, we're trying to look at what goals we would like to see the patient to achieve. And again, we always need to include the patient in those goals. We have to always think about the importance of that therapeutic relationship. That is probably um, the key to working with people with this disorder, is developing that therapeutic relationship. If you're able to develop that relationship, you will be much more successful at avoiding the manipulative behaviors and just being able to be consistent and have the patient remain safe on the unit. I do have just a little quick story about a patient that I took care of who had borderline personality disorder way back in the early 80s when I was a pretty new graduate nurse. And yeah, I think I'd been out of nursing school for maybe a couple of months and just got my license. And I was so excited. I was working on a mental health unit. And one of my primary patients, we had primary nursing back in those days. So I admitted this patient. And then that meant that I was going to be her nurse every time that I was on duty. So she was my primary patient. And she came in with symptoms of, she said, symptoms of an eating disorder. So she had kind of diagnosed herself and said that she had an eating disorder and that she was anorexic. Well, she wasn't anorexic. First of all, her body weight was completely normal, and if anything, she was probably a little bit overweight. But the interesting thing about this patient was that she had a master's degree in mental health nursing, and she was a nursing instructor in another college in a nearby city. And here I was, a new graduate nurse, and just graduated from school and just got my license and had a bachelor's degree. I didn't have a master's degree yet. So I was feeling a little bit intimidated by this person who was a nursing instructor in mental health nursing, and she was my primary patient. So first of all, I had to get over that kind of intimidation factor. And I'm just laughing thinking about the importance of the therapeutic relationship. So I remember some of our early conversations, and I would be trying to have a therapeutic conversation with her, and she would sit there and start to criticize me and say things like, "You know, Mary, I think you're using reflection a little bit too much. Why don't you try using a different technique?" And so finally, I had to kind of stop that and say, I'm the nurse in this interaction. I'm the nurse, and you're the patient, and we're working together to try to help you to feel better, and just completely kind of, okay, put the kibosh on this criticizing my techniques as if she was my instructor and I was her student. So I really had to set limits and show clear boundaries, that I was the nurse and I was in the helping role, and my role was not to be criticized for my lack of therapeutic communication. Anyways, so I always kind of think about that and laugh. The other thing that really solidified our therapeutic alliance was that the physician was, he was a really good doctor, and he just had a good understanding of her dynamics. And so he was kind of going along with her her saying that she had this eating disorder, even though she really didn't. She was refusing meals. She wasn't eating anything. And so the doctor ordered me to make milkshakes for her 3 times a day. So after she had the conversation with the doctor and he left, and then he told me, he said, you know, Mary, I just ordered milkshakes to be made for this patient 3 times a day. So the doctor walked away, and the patient looked at me and she said, "If you bring me that milkshake, I'm going to throw it at you." So, okay, so I went in, so I didn't respond at all. I went into the kitchen and I made her milkshake and I brought it to her. She was sitting all by herself in the dining room, and I was a little bit nervous bringing it to her because I was kind of looking at the clothes I was wearing that day, thinking, well, do I care about my outfit? Because we wore street clothes back then. We did not wear scrubs, so I was wearing my own clothes to to the hospital to work. And I kind of was like, well, do I care about this outfit? If I get it thrown at me, whatever. So I was a bit nervous, but I really tried very hard to be very confident and very firm. And so I walked up to her and I put the milkshake on the table in front of her. So what do you think she did? Any guesses? So maybe some of you are thinking, she picked it up and she threw it at you. Well, actually, no, she didn't. She picked it up and she drank it. So you might think, why did she pick it up and drink it? I'll tell you why. It has to do with the therapeutic relationship and the development of trust. I did what I said I was going to do. The doctor ordered something for her. I was following the doctor's order. We were working, she could see that the doctor and I were working together as a team and that we were going to be consistent and that we were going to meet her needs. And if you think about it, food is really a big symbol of nurturing. So many people really like that aspect of food and they feel very loved and taken care of when they're offered food. So in a way, I think that I was probably meeting some of those dependency needs and definitely trust because I said I was going to bring her the milkshake. The doctor told me to. It was an order. I had to do it. And I did it in a very neutral, matter-of-fact manner. Here's your milkshake. And she drank it. So that was the beginning of us working really well together and developing a good, trusting relationship. She knew she could count on me to do what was the best thing for her. So, anyways, just a little story because I think that really highlights the difficulties and challenges that we face with somebody with this disorder, but also that it is not impossible to form a therapeutic relationship and to work really well with patients that have this disorder. So, providing clear and consistent boundaries, clear, straightforward communication, calmly review therapeutic goals, teamwork and safety, and just responding matter-of-factly to those superficial self-injuries. So if they cut themselves, we do not want to overreact, over-respond, make a big deal about it, or chastise the patient and say things like, well, why didn't you call me first? What did you do that for? Why did you cut yourself? Making them defensive. We really don't want to do things like that. We just want to certainly assess for signs of infection, but just treat it very matter-of-factly. If we can, try to help the person reflect on what was happening before they cut themselves. So not that they did it in order to annoy you or to make more work for you. Pharmacological interventions, usually psychotropics, are geared towards, again, relief of symptoms. There is no particular medication that is specific for borderline personality. So they may have antidepressant, antipsychotic medications, or anti-anxiety medications might be used, mood stabilizers, all of those. And again, they may have some comorbidities and may need some specific medications for their other diagnoses. Advanced practice interventions, they may need to assist staff in therapeutic alliance. Many times when you have somebody with this disorder, you really do need clinical supervision. So you need somebody who is at a higher level than yourself to kind of help you to clearly see what's going on in your interactions and to try to help you to respond more therapeutically and just with a real understanding of their dynamics. So people with this disorder aren't trying purposely to get us upset, to get us angry, to pit us one against the other. They're not really trying to do that. It's all, their behavior is all a reflection of their inner turmoil and their inner dynamics relating to when they were children and they weren't taken very good care of. Psychotherapy can be very, very helpful, different types of therapy. There is something called dialectical behavior therapy, or DBT. You might hear that when we're in report on the mental health unit because it is something that's available in the Sheboygan area, and it is actually long-term therapy, usually about a year. The patient has to make a commitment for a year's worth of therapy, and it can be very helpful in trying to turn around some of the signs and symptoms of borderline personality disorder so that the person can live more happily and have better relationships. So schema-focused therapy, again, would be just another type of therapy that is a possibility that could be offered for people with this disorder. So again, a little comic representation, unstable moods ranging from joy to rage, intense, sometimes wonderful relationships. They become dramatic and sour over time. They really truly are terrified of abandonment, and they might do extreme things to keep you from leaving. Boy, they have a real hard time if you're going on vacation. If they're in the hospital and you're going on and you've admitted them and worked with them a week or two or even a couple of days, they may have a real hard time with you going on vacation. They may act out, they may be suicidal, they may cut themselves, really truly terrified of abandonment. It's really extra difficult too for them when when they're working with a doctor and the doctor perhaps retires or moves or somehow they're not going to be treated by the same doctor. Very, very difficult for them. And again, that's splitting into all good or all bad. So just a little representation of some of those symptoms. Now we're going to be talking about avoidant personality disorder. The prevalence is about 2.4% of the population. The characteristics are that these patients have very low self-esteem. There's shyness that actually increases with age. Sometimes kids might be shy in grammar school, middle school, or even high school, but then they kind of grow out of it as they get older and get more experienced and more mature. But this shyness actually increases with age. They have feelings of inferiority. They're just not as good as other people. At least that's how they feel. So therefore, they are reluctant to engage with new people. They have a really hard time meeting new people and forming new relationships. If they do have relationships, it's usually with people that they have known for long time periods. They are subject to depression, anxiety, and anger issues, and they are preoccupied with being rejected by other people and being humiliated and feelings of failure. They never quite feel that they measure up with other people. So guidelines for nursing care is that we have to use more or less of a friendly, a neutral friendly, not overly friendly, but accepting and reassuring approach. Accept the patient's fears as being real for them. It's never a good thing to tell somebody, oh, you shouldn't worry about that. Just go ahead and do it anyways. Conquer your fears. They just really can't do that. So we have to accept where they're at and how they're feeling. Of course, we want to help them and move them forward so that they don't have as many of those avoidant type behaviors. Group therapy can be very helpful, even though they may not wish to engage in it again because they would tend to find that threatening. But if they engage in it, it's very helpful. They can go through different types of exercises to enhance their social skills. So practice in interacting with people and in different types of situations can be very helpful in them learning to accept themselves in those situations and design exercises to prevent failures and certainly assertiveness training, because if they're having this personality disorder, many times they aren't very assertive. They're not going to stand up for themselves and to stand up for their own needs and feelings. So again, a little bit of a comic strip representation. So we might think of that person as being cowardly or fearful. They want close relationship, but they just don't take risks and they avoid situations. So it's very hard to meet people, very sensitive to rejection and negative feedback, and that makes them even more withdrawn. They feel shy, timid, socially inhibited, again, low self-esteem, and they say things like, I'm so incapable, inadequate, and undesirable. So they really do feel those things about themselves. Again, another couple of different, bunch of different comic strip representations, actually. So you can kind of read through those, and these are all actually very, very typical. I'm going to highlight number 6 down at the bottom. Talks about being reluctant to take risks. So the friend is saying, let's play charades. And the person with that disorder is saying, no, I'm just going to embarrass myself. I actually know somebody with this disorder, and it is very difficult to find any type of activity to do with this person. So many times will suggest something like, oh, let's go play miniature golf. Nope, I'm not as good as you are, so no, I'm not going to do it. I'll get really upset and angry, and my score isn't going to be as good as your score, so I'm not even going to try. Very, very difficult to do anything with this person except perhaps go out for a meal. That would be the only thing, or maybe to go to a museum or some kind of a sightseeing type of adventure, but certainly nothing that is even the least bit competitive. So, yeah, they really do feel they're never going to be as good as other people, and they feel like people are going to laugh at them. So, yes, so this is really very accurate little comic representations of this disorder. Dependent personality. Prevalence is about 0.5%. Characteristics. People with this disorder have a high need to be taken care of, and submissiveness, fear of separation and abandonment. They might manipulate others to take responsibilities away from them. And they have intense anxiety when they're left alone, even briefly. So we haven't covered domestic violence or domestic abuse yet, but think about this when we do come to that learning plan. Think about dependent personality disorder and how many of these personality characteristics can be evident in women that are in abusive relationships. So I think that's a connection that maybe hopefully that you'll make later when we go over that learning plan. So guidelines for nursing care, we want to help them to address their stressors, and we don't want to make the patient feel punished because they truly have, again, that inner conflict and inner dynamic that makes it very difficult for them to be independent and to make their own decisions. So we have to be aware, again, that self-awareness, always be aware of strong countertransference. They might remind us of somebody that just drives us crazy in our own personal relationships, or maybe somebody who is dependent on us. And so we can really have a very strong negative reaction that would not be therapeutic. We can use that therapeutic relationship with them as a testing ground for assertiveness training. So it is really helpful sometimes to use things like role playing with a person with dependent personality disorder and to try to get them to practice interacting in a more independent and assertive manner. And certainly psychotherapy would be absolutely the treatment of choice. So again, a little comic strip representation. On the left, difficulty making everyday decisions without excessive reassurance. So that's one of the things that you will pick up on. So this person is saying, should I wear the white or the black shoes? Are you sure? Are you positive? Wait, Chris, come back here. So they really have a hard time even making simple decisions by themselves without that external reassurance. And then the need for others to assume responsibility for most major areas of their life. So again, difficulty with decision making. So this is age 17. Mom, what should I major in college? So if a person has that disorder at that age, it's probably going to persist all the way through unless that person gets some therapy. But again, major life decisions dependent on other people to assume that responsibility for them. Obsessive compulsive personality disorder. Prevalence is about 2% to 8% of the population, and the characteristics are rigidity and inflexible standards for others and themselves. They're constantly rehearsing social responses because they actually tend to have difficulty with social situations. They have excessive goal seeking that is self-defeating or relationship defeating. So it's kind of like the old adage of beating a dead horse. So it's just they keep going on and on and on, way beyond the point of usefulness. They have strict standards that interfere with project completion. So even though they might seem like they're really organized, they're very clear, they've got these great standards and everything needs to be just so, Sometimes the project never even gets completed because they have so many hang-ups in trying to get that project completed. So actually their rigidity and those strict standards kind of interferes with their productivity. So they may not get things accomplished at all. They have a very unhealthy focus on perfection. Now, it's not that it's a bad thing to have some perfection, because you know what, in nursing, this is kind of a personality disorder that actually could be somewhat useful in nursing, because if you think about it, we have to be pretty rigid when we're thinking about being working in surgical areas and setting up a surgical field and doing a sterile dressing change, and things have to be just very, kind of done very rigidly. So, yeah, some of this might be a little bit helpful in nursing, but again, we can get to that point where we're so hung up on all these rigid details that we don't actually accomplish a whole lot. So, guidelines for nursing care. We want to try to guard against power struggles with people that have this, because they certainly would want to engage in those, and that we have to remember that the patient has difficulty dealing with unexpected changes. They really like things to run like a tight ship. Everything happens at a certain time, and they really get thrown off when things are something difficult or different is thrown into the situation. Um, these patients do tend to seek help. They tend to seek help for anxiety and depression that they might experience along with this. Group and behavior therapy is very helpful, and they might need some medication for their thoughts if they do have some obsessive thoughts that are interfering with their productivity, and also anxiety and possibly depression. The thing is, this disorder is different from OCD in that the patients don't have all of the compensatory mechanisms. So they're not doing the compulsive hand washing or taking a shower for hours on end and checking and rechecking. They're not doing some of those things. It's really more of a personality style, and that they are just very rigid and have difficulty dealing with unexpected changes. So again, a little comic strip representation. So they're obsessed with orderliness, perfectionism, complete control. They usually, if they're working together with people on a project, they want things done their way. And they have a great deal of difficulty listening to other people's ideas and opinions. And sometimes they might pretend like they're listening to your ideas or opinions, but then they go ahead and do it the way that they wanted to anyways. So having that complete control. So as you can see, people that have this disorder might be really difficult to work with. So think about if this is one of your coworkers or somebody that you're on a committee with. Very, very challenging and difficult. So they're very focused on rules, details, schedules, and they're very inflexible. So, little discussion question. A patient admitted to your unit has a personality disorder. What are some important areas to assess? And of course, we have to think first and foremost about safety. So, suicidal and homicidal thoughts, depending on what the disorder is. If they're present, the patient needs immediate attention. Always have to look and see if there's a medical disorder, possibly, or a substance abuse disorder that could be accounting for some of their symptoms. We have to view their personality functioning from the person's ethnic, cultural, and social background, ascertain whether they have experienced an important loss. So personality disorders are exacerbated after the loss of significant supporting people or in a disruptive social situation. So like I mentioned with borderline personality, even if the doctor is going on vacation, they're going to come back. But if they go on vacation, that can really set somebody into a tailspin who has that disorder. Evaluate for change in personality in middle adulthood or later, which signals the need for a thorough medical workup or assessment for unrecognized substance abuse disorder. So usually these patterns are evident earlier in a person's life, and if all of a sudden in middle age they start to have some of these characteristics, it's very possible that something else is going on. Another audience response question: which behavior indicates that a patient diagnosed with borderline personality disorder is improving? A, the patient cries when her roommate refuses to go to the dining room with her. B, the patient yells at the group facilitator when he points out that she is monopolizing the group. C, the patient informs a staff member that she is having thoughts of harming herself. D, the patient tells the evening staff that the day staff excused her from group to smoke when she got upset. So I am hoping that you picked C, because that would be the most mature behavior and the behavior that shows the most insight into their own behavior, and that person is really trying very hard to avoid maladaptive coping. So if you inform a staff member that you're thinking about hurting yourself, that means that is actually a huge step with especially borderline personality, because it tells you that they're actually not as impulsive, that they're thinking about the consequences of their behavior, and they're willing to work through that and cope differently. So that is the end of Learning Plan 4.